Good evening, everybody, and thank you for joining the Digital Health webinar and seminar series now being held virtually to people around the world. Normally our monthly seminar, because of the coronavirus outbreak in New York City, has been moved to a virtual webinar. And tonight's topic is digital health interventions for patients and for physicians in the age of COVID. Very appropriate topic given what we're in the midst of, and a very serious one. One of the most serious ever covered, frankly, and is one of the world's preeminent digital health labs. We will be airing more of these over the coming weeks and months, most likely, to help patients and physicians, clinical researchers, and managed care leaders, leaders from life sciences, national health systems, hospitals all over the world, with how and where to grapple with the coronavirus outbreak by using digital health technologies. Just a reminder that this series has been brought to you by and presented by Information Media Corporation. For the past 20 years, the team, including Alan and Michael and Joanne and all the rest, have been providing the world with some of the leading medication adherence technologies out there. And we're really happy to be working with them on this important work. Tonight we have with us an extraordinary panel that's diverse, not only in terms of their locations around the world, but also in terms of their backgrounds and their experiences, including Dr. Rosalind Parkes-Ratanshi, the director of the Ugandan Academy of Health, Innovation and Impact with the Infectious Disease Institute. Rosalind, if you could please do a quick 1-minute overview of your background for the audience.
I work both at Makerere University in Uganda, but I also hold a joint appointment with the University of Cambridge in the UK. And my background is mainly HIV, and moved into digital health work, and really looking at how we can use new technology solutions to make sure that we use our limited resources in resource-limited settings most efficiently.
All right, fantastic. Thank you again for joining us. We know it's very late there right now, so we're especially appreciative of the late hours that you're bringing in. Again, very excited to have her join us. She's been a part of fighting numerous outbreaks and epidemics in Uganda over the past decade, including swine flu, obviously HIV, AIDS, and Ebola. So her background will be immensely important in this discussion, as she's able to bring in her experiences from past epidemics and outbreaks and what we need to do, not only as a city, but also as a nation and as a global ecosystem to fight what we're currently fighting. Also with us tonight is Dr. Marcelo Venegas. He's a specialist in HIV and hepatitis. He's a physician who's been around New York City his whole life. He's also with the co-founder and the CEO of KnowNOW, and he is in the middle of fighting this epidemic from the front lines in New York City. Marcelo, can you give a little bit more background on yourself as well?
Absolutely. Good evening, everyone. Good evening for us here in New York. I am HIV specialist. I'm also an ER doc by training and internist by training. So I work in an urgent care setting here in New York. And I'm very happy to be here, even though we're all quarantined. Well, I've been quarantined, but I'm coming out of it now, happy to say. We're all, in a moment of really keeping our distance from others. And this is a wonderful space to be able to come together. This is like the third panel that I participated on today. And it's really wonderful to have this technology, even this technology here, like Zoom and others, that allows us to come together in this critical time and share our experiences and share what we see going forward. So I thank you, Stan, for inviting me and for being able to participate today.
No, super. And again, I think that the perspective that he's bringing in, everybody, is that he's literally on the front lines. I've been talking to him. I've known him for quite a while now, and just over the last 3 months, I've been talking to him almost every week and getting reports about cases coming into the ER, ICU, pneumonia, all kinds of flu. So we knew that this is coming down the pipeline, and that the not rate that we're currently looking at is something that's obviously troubling, at least in New York City. We're seeing it die down in other parts of the world, like certainly Taiwan, Singapore, Japan. China had its first day yesterday without a new case in months. So there's hope out there. Also joining us tonight is one of the premier oracles, if you will, of digital health, a personal friend and a colleague of Eric Topol's. From San Diego. Don Jones was working with Qualcomm in the early 2000s, creating the ecosystem for what we know as digital health today, helping the Qualcomm team put chips in just about everything medical. But Don, I'll let you, Don is the Chief Digital Officer at Scripps Research Translational Institute and the chair of Cardiff Ocean Group. And Don, I'll let you give a little bit more background on yourself as well.
Hello, everyone. Former Chief Operating Officer of American Medical Response, the world's largest EMS operation, and the originator of a strategy that rolled up a whole bunch of physicians into what's now MCare with 28,000 physicians. Then multiple other physician practices, including the largest private practice in Mexico, where I was the founder and chair of that group. And then 11 years at Qualcomm, where I built their digital health efforts. Last 6 years, I've been chairing and or on boards at a combination of large companies and venture-backed and PE-backed companies in digital health. And I also spent 6 years on the board of American Telemedicine Association. Thank you, Stan, for the invitation.
No, thank you again, Don. We know how busy you are. I mean, all three of you are swamped right now with what's going on, and we really appreciate you taking an hour out today to help educate people around the world around specific digital health innovations that can be helpful today with people, both patients and physicians and other people who are putting these together. This is obviously unprecedented times for most of this generation. The last time we saw something like this was actually 2009 with what was going on with swine flu. Before that, we had a scare with Ebola, and the numbers, the mortality rates and the infection rates were extraordinary there. And then obviously one of the most deadly pandemic is HIV/AIDS, and that's been going on for decades. However, it's in terms of the not rate and the infection rate, we've seen extraordinary digital health technologies help with not only the surveillance, but also the treatment of HIV/AIDS patients around the world. And certainly, I think all three panelists tonight can talk about that. And then the pandemic that we have all been reading a lot more about these days because of the global mortality rate that we saw in 1918 was the Spanish flu. And I think that's one that's top of mind these days for everybody, either from public health circles or from the patient's point of view, and everyone's concerned about that. So as a framing, if you will, that gives you an idea of what we're looking at. One of the most useful digital technologies and digital resources today is something that came out of Johns Hopkins a couple of months ago, the COVID-19 Resource Center at Johns Hopkins has a website that allows patients, public health professionals, physicians to track the actual spread of what's happening with coronavirus. And if you take a look at the next slide, you'll see an illustration of this. And again, if you just go to Google and Google the Johns Hopkins Coronavirus Resource Center, you'll see a graphic like this that will help give you more information. Now, again, in this age of information overload, that might not be something that you want to see, but for a lot of folks that are trying to understand and make sense of this, this has got a lot of good data. certainly will help you understand the regions and the areas that are being affected the most. There are hopes, and I said this earlier, there are some great signs in terms of how social distancing, testing, surveillance, and quarantine has actually worked in nations such as Singapore, Taiwan, Japan, specifically China and Wuhan has seen the strategies, however immense, that needed to be taken work, and have not only cut down substantially the number of new cases, but as of yesterday, at least, no case reported, no new case reported. And then we've seen in Vietnam, where Vietnam had a number of cases January, February, then they had a 3-week spurt where they had no new cases and it was looking very good. And then all of a sudden a new case popped up and then 60 cases popped up. So one of the things from a digital surveillance standpoint is that there are extraordinary elements here that everyone is playing with in terms of the rebound effect of the virus coming back, and having digital health technologies around to track that is absolutely critical. So with that background, and let's go to the slide that talks about all of the digital technologies that we're looking at right now: telemedicine, artificial intelligence, clinical decision-making, robotics, certainly electronic health records, drones, disinfecting. There are a number of digital health interventions that we've seen take the stage. And Don, since you're on camera now, let's start with you and just some of what you're seeing from the front lines of San Diego, of California. You're on several boards. What are some of the most diffusive and currently implementable technologies that you're seeing help combat this virus, both from the patient's and the physician's standpoint?
Well, let's talk for telemedicine, not because it's the most obvious, but because the workloads coming on the telemedicine companies are actually crashing systems. So at a high line revenue, one company in discussions with has seen more patients this month of March than they have in the previous 12 years combined. Other companies report upwards of 500% increase in demand. I'm aware of, and I have actually 2 financing requests for telemedicine companies, both approaching over $100 million to dramatically expand the backbones and service capabilities. So while telemedicine holds a lot of promise, we're stretching its capabilities. A second category that's promise coming up from early stage companies is using AI based solutions predicting decompensation. And there's a number of companies in this space. PhysIQ, which has been around for quite some time. Actually, we started out, one of its first definitive trials was in Africa and in Sierra Leone around Ebola patients. But they have a pretty proven system for decompensation tracking. We got 9.5 days through the Scripps study and with the Ebola patients. So no symptoms. We were able to predict decompensation 9.5 days before it occurred. They're now working with COVID-19. So is Peach Telehealth, a company that comes out of MIT, five branches of MIT. Also has some ties and has been working in hospitals in Singapore, and then Bioformus, which also originates in Singapore. Peach Telehealth is interesting because it not only is predictive in terms of decompensation, but it also predicts actual future signs. And then finally, I think in terms of changes that we've seen just recently, literally in the last couple of days, is the notion of using mobile phones for tracking purposes. It's got a lot of potential controversy from a privacy point of view, but there's a benefit also to patients. And one of those benefits that we're seeing came out of an MIT launched app that just was today called SafePaths, which essentially allows people to volunteer their COVID status and then lets you know whether you've come in close contact with somebody else who's already exposed, or who has actually has the virus and has been tested positive. So this concept of tagging and tracking is something potentially governments could employ using mobile phones. It really ties on to the concept of using your phone number as an individual ID, and then using that not only for messaging, but also for this idea of creating a virtual 6-foot perimeter, or maybe wider perimeter around you, and then reporting on those movements and or trackings and as they go along. We've also seen an effort that the government has talked about, but it's not quite yet, that has worked with Facebook, Google, to again take in cell phone-based location to keep track of spreading. So those are the big areas. I have to decide. I've got 5 more companies to give you some examples of what some individual companies are doing. But those are the big areas of medicine, AI, and using mobile phones as part of a solution.
That's fantastic. And, you know, I think looking at the telemedicine component, we've just never seen anything like this before. And obviously, the companies you listed off are the ones that are seeing just extraordinary amounts of volume right now. Marcelo, from your standpoint, is, you know, sitting in the front lines in New York City and working on this, what are some of the digital health technologies that you've seen people utilizing in, you know, either as patients coming in trying to manage this either through devices or apps, or from a physician standpoint of trying to use telemedicine and remote patient monitoring or other types of remote tools when you're in an ICU, you've got a hazmat suit on and you're trying not to get any kind of exposure to the patient. What are some of the digital tools that you're seeing?
So, you know, I think it's a terrific question. One of the issues we've had is actually not having providers go to specialty clinics to see their patients. I think the social distancing has hit everybody very hard in the last week, and even the last 2-3 days. So, for example, we have examples of dentists still seeing patients for like emergency procedures that weren't quite emergency, and the risk of just spreading through contact. We at our specialty clinic that I work out of, AIDS Healthcare Foundation, we just stopped seeing patients this past week and moved over to just simple telephone. But we didn't because the telephone guidance came down from the state allowing telephone communication. New York has been one of the states that historically has not allowed, had been very firm around telehealth virtual visits that have to be in real time. That has been just to try to limit the amount of abuse that can happen from providers not being diligent in terms of doing a quick visit and over the phone. But that's quickly changed, and obviously now it's acceptable. And so I've actually done some calls that had the company that I've worked for already had telehealth, for example. It would have been much, much easier. And so people were really caught unprepared. And I think many, many health systems are unprepared at this moment to do telehealth. And so it's been, even you've read in the news recently that some of their systems have crashed, where they've been completely overloaded with telehealth visits, that their systems were not able to maintain capacity or maintain the accuracy of their visits, or their systems went down. So I think it's been a very, very interesting time in the last, let's say, 3 days, last 72 hours, where folks have scrambled for telehealth. Folks are giving up on it altogether because they're not ready, or because simply there's alternate ways as using the phone. It's good in the short term because sure, we can have phone calls for visits, but in the long term, this is going to be going on with us for at least, it's predicted, to another 5 to 6 months minimum. So that I think it's an ideal time for both companies that are telehealth companies to get new clients on board, but also to really look at the what is the workflow and look at what is the capacity of telehealth. So I think, you know, in terms of social distancing, it's ideal because you don't want those mildly sick patients to be, you know, occupying your emergency room or even the tents that have been set up. I just got a colleague call me from Elmhurst Hospital here in New York, and it's complete chaos. There's like, this is in Queens, there's like a line outside the door without people with masks on. And then one of the nurses was just doing the swabs indiscriminately, you know, and so you talk about chaos that can be really curtailed had this hospital system set up a telehealth system from the beginning and told patients, hey, stay home, look us up on the app, and tell us what are your symptoms. We can get you either tested if necessary, or at least have some kind of triaging that could have happened way back. And so not only here in New York are we at a disadvantage from lack of testing, but we've been at a disadvantage from lack of technology. Or had this technology been implemented, 6 months ago to a year ago, we wouldn't be caught in the situation we're in right now.
That's absolutely true. And, I think one of the things that we're seeing here as well is that there's, an enormous push to try to figure things out. So with telehealth comes a whole new local, county, state, federal reimbursement mechanism. So people are scrambling to understand, what do they use as a coding mechanism for telehealth? What kind of documentation do they need to get reimbursed? So certainly the front lines and all of the activity on the outside of the ER and the ICU and the waiting rooms are also happening in the back offices of hospitals, of managed care organizations, of health plans, of people deeply involved and enmeshed in the healthcare service delivery. And let's go to Uganda and Rosalind. Rosalind, tell us a little bit about what you've done in the past. You've battled a number of epidemics in Uganda around HIV/AIDS and certainly swine flu and Ebola, and now you're preparing for the onslaught. I guess the last numbers I saw in Uganda was that you guys are getting ready. You're implementing social distancing, but you haven't had a ton of cases arrive and come into Uganda yet. And it was funny when we talked last weekend. You mentioned how you had been quarantined because you had come back from that epidemic hotspot, the United States of America, and so they quarantined you coming to Uganda. But from your standpoint, what kind of digital health tools are the most effective in fighting this over the long term? Like, Marcelo just mentioned, 6 months or more in the United States. What do we need to look at here?
Thank you. So we are in a slightly different situation in Uganda and in many resource-limited settings, which is that people are still very reliant on mobile phone systems and not so much on data-driven internet solutions. So for us, our first port of call will be digital solutions or mHealth solutions relying on mobile phone technology, because that's the most readily available to the majority of the population. We have increased penetration of the internet, but that also tends to be mainly in our urban settings and in the middle and upper classes. So we can work with healthcare workers through internet-based solutions, but when we want to access rural communities and even healthcare workers in rural settings, we will have to go down a mobile phone type route. So really, given our fragile health system, what we are concentrating on and where we have the most chance of actually controlling is very much in our preventive and surveillance. So Uganda has been, like our colleagues in Kenya and Tanzania and elsewhere in Africa, extremely proactive on returning traveler surveillance and returning traveler quarantine. As mentioned, today was my last day of quarantine after having been in the US at Hopkins and coming through New York 2 weeks ago. And what there is the capacity around there to automate and digitalize some of the surveillance responses. So, for example, we're working with the Ministry of Health to try and implement an interactive voice response system that we've worked. It was originally developed by Janssen, Johnson & Johnson, and we've been working with it for the last 5 years on adherence support for HIV patients. It calls them every day or every week and encourages them to take their tablets. We've adapted that system to be able to call returning travelers or contacts of COVID every day to ask them if they've got symptoms. Right now, what the Ministry of Health is doing is sending somebody out on a motorbike to check on people on a daily basis to make sure they're still in quarantine and they haven't got symptoms. This, we can automate it and do it remotely. The other types of activities that are happening are really around case management and healthcare worker training. So many of the mHealth solutions based with the mobile phone networks, such as Safaricom in Kenya and Pensa in Mozambique, they are using their information systems where they've provided information to the general public to give out information about COVID. And then there are lots of digital health groups who work with community healthcare workers who work down at a village level. And they have already been doing disease surveillance, healthcare worker, lay healthcare worker support and training. And they are adapting their platforms for COVID at a village last mile health level.
That's brilliant. That's absolutely brilliant. And so when you look at what's happening in the United States and you look at the technological tools we have at our disposal, if you were the head of healthcare in the US, what would you be funding? What would you be trying to accelerate the diffusion of to try to help save these lives at this precious time?
So I mean, I think that Don has mentioned, well, Don and Marcelo have both mentioned some things. I am not an expert on the US health system, and from the UK, our public health system is very different. And because of all our care comes through the National Health Service, the UK has the ability to monitor and track more easily because it's more linked up. So I think what the sort of public health measures that Don has mentioned, such as using the big tech companies to support public health type activities whilst they have potential ethical and legal challenges, I think that they are the types of things that are going to make a difference in terms of monitoring and tracking. So I heard, for example, in Austria today, I have a PhD student who says that in Austria, the government are tracking mobile phones to make sure that no more than 5 people are meeting together in a group. So they're looking at where mobile phones are congregating to make sure that people aren't having group gatherings. And apparently there's a fine of about $3,000 if you're in a group of people and you're having a meeting over the registered numbers. So I think there are some innovative ways of using our mobile phones to also enforce social distancing, which as we get into more and more of a crisis situation and as our kind of takeoff, epidemiological takeoff happens in different countries, we may need to do more of these public health type interventions using phones such as Don and Marcelo mentioned.
That's fantastic. And I think that's really interesting because we've seen that now in India where a traveler came back into India from Italy and was diagnosed with coronavirus, and immediately the government tracked their cell phone in the previous 5 days and immediately quarantined 1,000 people under guard to make sure that the virus didn't spread. And so India, a country with a massive land border with China, Iran, and the Iranian-Indian relations are phenomenal. They've seen only less than 100 cases so far and no deaths. So we're seeing Israel do the same thing with mobile phones and track and surveil any positively tested patients as well. So the mobile phone technologies during a time of crisis like this, and some people have called it a war, all of a sudden the civil liberties that people expect with mobile phone tracking and identifiers, they become a really much more of a civil privilege than a civil right. So it is interesting to see how these national health systems and these national governments are working together to reduce the spread of the virus. And let's talk about that a little bit. Don, you've had an immense amount of exposure to the wireless industry. Obviously, that kind of patient privacy controversy you're familiar with, having worked so long with Qualcomm and understanding healthcare long before that and being deeply involved in healthcare before that. What are some of the ethical and legal considerations that we can consider mitigating during the pandemic, that we have to consider mitigating during the pandemic, aside from, cell phone privacy, if you will, for folks who are diagnosed?
Well, interesting. Rosalind brought up the Austrian situation, because the availability of where cell phones are pinging from is actually already visible through the carriers to government agencies and the police. There's no permission. They don't have the identity, but how many pings are occurring and the location of the pings. So those maps are readily available today, and already available and visible to the carrier. Once you start identifying them, that starts when it starts crossing the line. But the interesting part from my perspective is if we put out the appropriate apps, the COVID app that actually gives the consumer something back in value. For example, have I been exposed? Have I been near exposure? Should I stay away from this area, et cetera, et cetera? Then perhaps people will volunteer to participate, and you won't have to force anything. So there's kind of a question of a quid pro quo here, and can we put out the appropriate arrangement that people will say, okay, there's a benefit for me to be registered to this system, maybe I should register it. And certainly there would be an opportunity for the largest companies in the world, Google with Android and Apple with iOS, to actually potentially put that in place and create that incentive for consumer to participate. We're seeing a little bit of that in a different way. Today, Elon Musk announced that he's looking at how to take his factories and his understandings from the much more advanced air conditioning systems in Teslas, as well as his experience with the spacesuit industry, and start making ventilators. Anybody is going to start making ventilators next week. In fact, it would be Elon Musk. So maybe, and now we've actually seen the other big car manufacturers actually come out and said they're looking into how to convert their assembly lines into ventilator lines. So maybe Elon is onto something. But I think what we're going to go into MacGyver mode, and so I think everybody to a degree is going to be into this mode of I make do with what I have, and how can I improve upon the things. But understand that a lot of concepts about privacy are likely to go out the window, voluntarily, otherwise, under extreme conditions.
That's fantastic. Yeah, and then going back to Marcelo, Marcelo, from your standpoint, what are some of the digital health technologies? How can the digital health technology community, we have just a ton of people online right now watching this, what would you ask the digital health technology community to provide to you as a physician on the front lines, or to your patients who are walking away being diagnosed or going into ICUs?
Yeah, so I mean, I wear two hats. One is we are a provider. I have the company, which is KnowNOW, which you know well, Stan, which we started off very simply offering STD testing and PrEP 2 years ago. And now we're in the business of actually selling the technology because the state realized how important it was. But at the same time, the safety net of the United States is FQHCs, federally qualified health centers. That's where the majority of poor folks get their care. And a recent RAND report, which I've shared with you, Stan, before, showed that the majority of those clinics, which is a total of 14,000 when you include the lookalikes, don't have access to telehealth. So we see a huge disjoint between those who are serving particularly the poor in the United States and technology. And we really have, and no one can argue this, whatever political spectrum you're on, we have a disjointed and broken down healthcare system where the number one reason for bankruptcy in the United States is medical. So we're going to be looking at a whole, not only are we in a recession that we're going to go into, but we're looking at, I was talking to some folks yesterday, and the unemployment rate is going to just go through the roof where, like just talking about the New York example, half the people that are working in the service industry have been laid off. So you have a whole bunch of people without jobs now, and you have a whole system that does not necessarily allow for that technology to come through. And so we're caught in a real mess here. And I'm really, really worried what's going to happen a week from today, or even less, 5 days from today. When you look at, I don't know, do you guys have the slides, Stan, or can I share directly from here?
Yeah, share directly from there, sure.
Yeah, give me just 1 second. Let me see if I can show my slide here.
I think you're talking about the increase rate, right? That you wanted to.
Yeah, I just wanted to point to that. Just give me 1 second.
In the meantime, for folks who are attending, please go ahead and start asking questions if you want to have any of the panelists answer a specific question that you have around either the experience in Uganda or what's happening in New York City right now, or certainly some of Don's experiences in digital health over the last certainly 20 years or so.
Can you guys see my screen?
Yeah, it's live.
Okay, great. So if I can just show here my slideshow really quickly. In terms of just not even symptoms, I think just important just to overview in terms of like basic education. People are calling, oh, do I have a sore throat? Could it be corona? I think it's really important to get the education out. We've been trying to do that from the beginning. And this whole idea of staying home, social distancing is a way to not contract it. I want to share this with you guys. This is actually my chest x-ray from a week ago when I was having dry cough. I didn't end up getting a CT of my chest, but CT is a way to diagnose many, and unfortunately that's not accessible to many people because chest x-ray can be normal and the CT can actually help you diagnose, and that's the case that was in China.
Now, what's the diagnosis? What's the time frame that you're able to CT a patient and see a positive diagnosis? Is that when they've been they're kind of 2 or 3 days into their symptoms, or is that or even asymptomatically?
Yeah, there's no exact time frame. It's more like if you're symptomatic with a dry cough and the chest x-ray can be normal, the CT scan would be fever, dry cough, achiness, severe achiness, which is usually of a viral syndrome like the flu, should prompt you to get a CT scan if you're like, let's say your saturation oxygenation is low. But what I wanted to point out is how this map is going to change the United States dramatically. From, this is as of today, we have 166 deaths here in the United States with 11,000 cases in all 50 states. If we look, and this is what I'm coming to is to show you how we're like Italy times 50, where you can't fight the math and you can't fight, in terms of the just the spread of a viral infection. But this is what I wanted to point to. This is by dates, with the first one here being Italy 2 weeks ago at 9,000, or that we can say around the same numbers. This was New York City. This was the United States on 3/16 was 4,000. New York was 954. Now our number here in New York has climbed to 3,000 as of today. So it was 954 on the 16th. Today's the 19th. In 3 days, we have tripled our numbers. And that's just New York City.
But a lot of that's the fact that testing is just coming online right now as well, right?
I think it's a combination of both. You know, I've been seeing patients for the last 3 weeks that have been pretty sick that I could have definitely thought was COVID. Right now, the number for the flu is all-time low in New York. So if you're coming in with those 3 symptoms of fever, dry cough, achiness, and so on, I think, you know, we've agreed as providers that you have coronavirus unless proven otherwise. But in a space of 72 hours, we've tripled our numbers, whether it's because of actual new diagnosis that we've been able to tell. But what I wanted to point is to the left side, you can see from 3.9 to 3.16, that number just blew up exponentially in Italy, where they had to essentially, you know, and I'm not trying to be an alarmist. I actually think I'm the exact opposite. I'm just trying to be as practical as possible to show how terrible of a scare this will become here in New York, and I think the rest of the country, where, you know, you're looking at an exponential increase in a matter of 2 weeks. So we've seen it in a matter of the last 3 days. And so this is really, in terms of technology, we can make a huge intervention, where my call would be to whomever is out there that has the technology to provide it for free. Our company is offering for free for the next 2 months, whoever wants to use it, because we think it's that much of a threat. No one should be seeing patients at a community level, person to person. It all has to be done through either video and that's a whole lot of people when you look at the 300 million people plus 320 million people plus that we have in the United States. Who's paying for that? I think it has to come from private enterprise. You know, I think there has to be some kind of sponsorship. There has to be some kind of, President Trump just came up with a lot of money to be used, but that has to be done very quickly. We can't wait to implement it, because a lot of times it takes at least a couple of weeks for onboarding.
Right.
And the other potential threat is that, you know, we're seeing that the Italian mortality rate has increased beyond the Chinese one, you know, which is quite interesting when you look at it. It's understood, the Italian has a higher age population, like older age, but if you look at the United States in terms of our baby boomers, we're right there with Italy. And so we've seen, we need to not only expand testing. I just wanted to talk about how how corona can last for several days on surfaces and how social distancing is so important. But what I wanted to show was, this whole idea that younger adults are being infected and that they're coming down with acute cases. And so my colleagues in the ER have been intubating 25-year-olds, 30-year-olds, here in New York. And so I really think this is a call for the millennial population to really stay away from others. Like yesterday, the shots of people in Florida celebrating spring break, it's something that is really, really concerning, particularly when you look at how it can affect elderly. So you may be fine if you're young, but the chance to infect an elder, anybody over 60, is really exponentially high. So it's kind of like a public health call at the same time in terms of, being able to address this as a collective.
That's great. So, looking at that too, let's get the perspective of Rosalind and really understanding, from the Ugandan side of things. Rosalind, if we can somehow or another improve medication adherence when people are discharged from the ICU, or even if we can help people free up hospital beds. One of the attendees right now is wondering how does that sort of compliance factor when you're working with patients who are currently ill factor into the equation? Has Uganda ever had any kind of persistence or compliance technology with their patients to try to free up hospital beds and send people home?
Well, it's not necessarily in terms of freeing up hospital beds, because we don't have that many. I mean, we've got 53 ICU beds for our 42 million population. So we are going to be in, I'm listening to Marcelo and getting increasing palpitations, thinking about, you know, our fragile health system. But I think, you know, people tend to be, human nature is that before you've got a condition, you are more anxious that when you've got it. And so I think that anything, if we are going to send people home on antiretrovirals, or if we're going to send people home while they're still infectious, anything that encourages them to keep self-isolation for the period of days that they need to, and anything that keeps them from you know, encouraging them to not pass on to other people is going to be vital, because human nature is kind of like, oh, well, I've got it now, so I can relax a bit. I think the attendee asked about things like smart bottles and medication adherence through the actual the tablet bottle, or a pill pack, or whatever, you know, the smart dispensing units. I think that those are potentially great ideas of making sure that people take their medication, but I think they also need to be used alongside constant messaging. You know, that human voice, either an automated human voice, or somebody calling, or somebody checking up, or some kind of check on symptoms, or checking how you are, I think is vitally important. One of the really interesting things we've found on our mHealth technology, and we've given out over 1 million calls to quite a small group of people, about 4,000 people. So these are people that are getting weekly calls and have done for 3 years, and yet are still picking up to that phone call, which I find astonishing, because I wouldn't be picking up an mHealth call after 3 years. But what they are saying is that the human voice and the contact that they have, and the way the voice speaks to them, that human side of things makes a difference to them still engaging with the digital technology. So I know populations are different and cultures are different, but when people are anxious like this, I think that there is a way of, as well as using technology, kind of dry technology, adding that human component is quite important. And what I'm also seeing is a lot of mental health tools, because I think the mental health practitioners have been quite far thinking in terms of using digital tools for mental health counseling and mental health support. I think there's also a whole load of ways that we can use or add on some mental health support to people who are either self-isolating, or who are sick, or who are families of people who are sick, or people who are very anxious.
Yeah, that's brilliant. And thank you, Rosalind, for bringing that up, because I think now more than ever, we're seeing an extraordinary influx for a lot of the online and the app-based mental health digital therapeutics. It's just extraordinary. This crisis has caused almost like a PTSD type of effect on tens of millions, hundreds of millions, probably billions globally of people who are being forced into social isolation. And, you know, it's not easy. It's very stressful. And, you know, from the perspective of my college-age daughter who was sent home from Europe, and, you know, who's in Penn State and living with her folks now to wind down her junior year, it's not an easy thing whatsoever. But from a serious standpoint, there are a number of people who are losing family members and relatives. And this is something that we're going to see not just this year, but years to come. Mental health resources needed, and digital therapeutics are a big part of that puzzle. That's leading up to our next question. One attendee is asking you guys what you think about the relationship between public health and digital therapeutics and life science companies, pharmaceutical companies. So when you think about how they are creating their products, should they be creating them with digital therapeutic adjuncts? And thinking about this particularly, you know, someone who comes up with either a coronavirus treatment or a vaccine, how can a digital play a role to help maintain the efficacy, to help improve the efficacy and the experience for that patient. Don, you've worked a lot with life science companies over the last 30 years of your career. What's the best answer for that one in terms of how to bring this forward during this crisis, after this crisis?
Well, in the traditional life science pharmaceutical model, I've worked with 8 of the top 10 pharmaceutical companies, and I can guarantee they're all working on combinations of apps and diagnostics and combinations where you have a device, a drug, and an app all together on all new products. That's a slow, long drawn process. How the pharmaceutical industry is going to play here in the near future is bringing resources to bear. So let me just tell you one of the things that's going on behind the scenes that you might not have thought about. The pharmaceutical industry in the United States employs 114,000 pharmaceutical reps. They're all sitting on their butt at home. They can't get in to see the doctors. The pharmaceutical industry is rapidly, like in the last few days, trying to figure out how to put people to work to solve some of the issues that we're talking about. Now, there's not an answer yet on the table, but there's a workforce that they don't plan to get rid of by layoffs at this point in time, and they were trying to figure out how to put them to work in a way that's productive for the problem at hand. So that's just one example. Another example that's just come up in the area where we've seen these digital health companies that are combining telemedicine plus direct-to-home fulfillment of the therapy. Company, you've all heard of them, companies like Roe and Hims and Hers. Maybe you've heard of Cove or Kix or others. But Everlywell and Nurx just announced that next week they will have home-based COVID testing kits available with instructions, with videos to show you how to do the testing, and then be able to be picked up or mailed in. So the industry is rapidly responding, but the life science industry, the biggest thing they can bring to bear is cash and human resources. This is in addition to obviously what the scientists are doing in the labs, working on vaccines, etc. And I think you've got some interesting opportunities. I've been involved in multiple discussions so far, for example, on how to put those pharma reps to work in a productive way.
So you are the oracle of digital health, Don. What do people do in clinical research right now? HITLAB, obviously a major digital health researcher, getting access to patients right now is virtually impossible. How do clinical research groups, how do CROs, how do life science companies conduct clinical trials today? Is there a digital health solution for people that are in the midst of trying to complete a study or start up a study, or in the midst of a study? Is there a digital health solution to help them with that?
Well, the reality is a whole lot of studies have been put on hold. In fact, I would probably venture to guess that the majority of the studies that are currently ongoing in the pharmaceutical life science industry are currently on hold. There are some that can't be put on hold for any number of reasons, especially you can think of some oncology studies. And so there are some companies, I'll just name one I'm familiar with, named Sanguine, which does one of the services it does is in-home sample and data collection. So they are getting requests. The majority of the requests are coming in have to do with getting samples regarding COVID trials. So it's various testing having to do with the vaccine development and plasma therapy development that they're getting their samples for, and they're going into the homes in order to acquire the various samples as required. But some of the clinical trials that can't be stopped for any number of reasons are switching over rapidly to in-home services whenever they possibly can. But this is going to be a very small percentage of the total tests. Basically, one of the industries that's going to be very, very seriously impacted is the clinical trials industry outside of the working on COVID.
Yeah, I think that that's certainly the case. I know at the lab, we're looking very carefully at being able to deliver the digital health technology to the home, doing video clinical trial consults, and then doing e-source to collect the data. So there's not a lot of folks that if you're doing an injection or a blood pull, you can't do that. So it's really restricted to some very unique and very specific cases there. And Rosalind, from your standpoint, have you ever seen a clinical trial workaround for people who can't go to the doctor and you're trying to do a clinical trial with patients remotely? Has that been ever an issue in Uganda? Rosalind? We may have lost Rosalind.
No, I'm still here. I just was on mute. I was saying most of our research in Uganda tends to be epidemiological and kind of adaptation. So post phase 3, where we are actually trying to use solutions that have been in phase 3 trials elsewhere and adapting them to our population. So that doesn't tend to be an issue. In general, we don't struggle to get people to join studies because there is so little resources that people see a huge value add to being involved in a clinical trial, because they may actually even be able to access healthcare that they wouldn't necessarily be able to get. So I don't think our situation is going to be the same. What our major problem is, or what my major concern is, we need to be able to get expedited IRB approvals so that we can actually study what's going on with COVID in our setting and document what's happening and do urgent work. I'm specifically interested in looking, if it does come to Uganda, at the outcomes in our patients who are already taking antiretrovirals versus outcomes in people who aren't. Because I think we can learn a lot from the ART that people are already, the antiretrovirals that people are already taking in country.
That's fantastic. Yeah, I think those are, I mean, when we look at the issues that are really going to affect this, that's certainly one of the major ones, is being able to utilize those tools for not only efficiency in this age, but also in this time, but also efficacy. So yeah, both critical junction points for us and ones we've got to consider. So we're winding down now. We have a few more minutes left, and you know, just Marcelo, going back to your point of view, given where you are in New York City, now that you're out of quarantine, now that you're going back to the front lines, are you thinking about bringing a different type of digital tools, apps, or are you thinking about recommending different types of digital tools to your patients, whether it's remote patient monitoring or Apple Watches or certain mental health apps on their iPhone or their Samsung or the Droid or the Pixel? What's your thought process as you're walking back into the ER, the ICU, and treating patients again?
So a couple of things. You know, Rosalind, thank you so much for bringing up the whole mental health issue. Stan, just like you, I have my 2 daughters who've been cooped up inside, and they're teenagers and they're going bananas. You know, we're into cruising through Central Park and letting them get out for a little bit and coming back in the car. But I think, you know, it's going to be a long-term issue. It's going to be a huge issue where mental health is going to be, not right now. I mean, right now we can tolerate it, but 1 or 2 months into this, it's going to become a huge, and already for existing patients who have mental health issues, in terms of being, you know, caught up in an apartment, usually in New York City, where there's not much space, and also just PTSD in general, in terms of what it means to have this. People are bogged down. I mean, people are really down and out because that's all they hear about in the news. That's all you're listening to, and it just gets worse and worse. And, you know, there's real threats and real misinformation going on. So I think it's the responsibility of you know, using those who are in the technology field to get the word out around what's important. And frankly, I'm also worried. I'm worried about things like Everlywell. And I know NEORX. I actually know them. A much more responsible company. Not to bring out around irresponsibility, but what it does mean to have a test that's not accurate out there, and that has not been approved. And so that's a little bit of my concern in terms of the rush to get things out. One of the concerns around Everlywell was they had the test for food allergies, and that wasn't confirmed. And then, you know, a lot of patients were coming to get tested that weren't corroborated. So, you know, in the same way, I just want to make sure that it's not around being able to isolate folks at this point, because it's more really around making sure they can get ideal care with even things going out there like hydroxychloroquine that was mentioned by the president, and people now running out to get it in terms of treatment. So what I'm trying to say is really we have a responsibility to our patients to get the right, education out there. Kaletra was not available, as you know, Rosalind. Lopinavir, ritonavir was not available because there was a mad rush to get it, and then the next day an article came out saying that it was not effective. And so it's a lot of misinformation going out there, and I think it's the responsibility of our companies to be able to direct patients in the right way, in a way that makes sense and is evidence-based. I think that's really our responsibility, and to connect the dots to really get other companies, like you mentioned, Stan, that have the technology to be able to be accessible to people out there. It's going to be a huge time of work. I mean, I've been working nonstop since 9 in the morning here on video, where we've been from across to Australia. I've been working with other folks that want to access telehealth, and using our experience and making it available to others, I think, is a key thing.
Agreed. All right. Well, thank you, everybody. Dr. Parkes, Dr. Venegas, Dr. Jones. Yes, Don, you are a doctor. If you have a JD, we're calling you doctor. And thank you for all the attendees, certainly. And most of all, thank you to Michael, Alan, Joanne, and the entire Information Mediary Corporation team for sponsoring this and presenting this. We really appreciate everyone joining us tonight. If you have any other questions, please don't hesitate to follow up. We'll get them answered for you straight away. And please, everyone, be safe out there and have a good night.
Thank you so much. Good evening.
Thank you.